Hello and good morning to everyone. Thank you so much for tuning into today's session on small fiber neuropathy with guest presenter, Dr. Amro Stino. My name is Lindsay Colbert. I am the Executive Director of the Foundation for Peripheral Neuropathy. And I'm beyond thrilled that we're doing today's program and hope that it will be of great value to everyone joining and watching again in the future. Before we get started, just a few logistical matters to address. First off, the webinar is being recorded for future access. We will upload the recording and related materials, including the PowerPoint slides that you will be seeing today, in the next 24 hours or so onto our website at www.foundationforpn.org. Towards the end of this session, we will be having a question and answers session. So if you do have any questions, feel free to submit them at the questions box. We will try to answer them at the end of our webinar. And if for any reason you cannot hear me right now or have trouble with your audio throughout the session, I encourage you to dial in by phone. That number is included in the email with the other instructions on how you access this webinar. And now I am pleased to introduce today's guest speaker, Dr. Amro Stino. He is an assistant professor in the Department of Neurology in the University of Michigan Medical School, Division of Neuromuscular Medicine. He has expertise in the treatment of neuromuscular disorders with special clinical and research interest in the care of patients with acquired peripheral neuropathy. Dr. Stino went on to pursue a Bachelor of Science degree in Brain, Behavioral, and Cognitive Sciences from the University of Michigan, Ann Arbor, which he completed in 2006. He received his medical degree from Wayne State University School of Medicine in Detroit, Michigan in 2010, and completed a transitional year internship at St. Joseph Mercy Hospital in Ann Arbor, Michigan. He then completed his neurology residency training at the Wayne State University School of Medicine, Detroit Medical Center, followed by a fellowship in clinical neurophysiology, neuromuscular medicine at the Mayo Clinic in Arizona. He joined the Ohio State University faculty in 2015 as director of the Peripheral Neuropathy Clinic and Autonomic Lab, and he joined the University of Michigan faculty in 2019 as director of the Peripheral Neuropathy Clinic and co-director of the Autonomic Lab. Currently, he serves as site principal investigator on multi-center studies in the realms of metabolic and autoimmune neuropathy. And today, we are so thrilled that he will be speaking today about small fiber neuropathy. So thank you, and I turn it over to you.
Thank you. Thank you for that introduction, Lindsay, and welcome to all our attendees. Hopefully everyone can hear and see me. I see that we have roughly 230 attendees and counting, so certainly the foundation picked a good topic, and I'm happy to help and contribute. I'd like to thank the foundation for their really impactful work in the field of peripheral neuropathy, both research, education, and in supporting us as faculty. So today I'll be talking on small fiber polyneuropathy or small fiber neuropathy, testing, clinical evaluation, and research. And this is a area that I think is now really well appreciated in the general medical community appreciated amongst patients as well. And it's unique in that it is a type of neuropathy that is not detectable on EMG or nerve conduction testing. So we'll kind of talk a lot about many different aspects of small fiber neuropathy today, and hopefully leave you with pearls that you can take into your clinical evaluation, as well as be aware of research advances in the field. So our objectives for today are to address somatic and autonomic testing modalities in small fiber neuropathy evaluation, SFN for short, appreciate the differential diagnostic considerations, and recognize various applications of small fiber testing, especially in the research space. And just to let the audience know, there will be 20 minutes at the end for Q&A. This talk should take about 40 minutes all in all. So what are we going to talk about today? So why this is important, looking at different fiber anatomy, different testing modalities that look at somatic and autonomic fibers. By somatic, we are simply referring to fibers that control sensation. So specifically with small fibers, it's in terms of temperature and pain sensation. Autonomic fibers are a different fiber type that really pertains more to what I call automatic functions. So your blood pressure, your heart rate, your gut, sexual functioning, those sorts of things. And there is some overlap with small fiber neuropathy. Talk about certain typical presentations of small fiber and then interesting applications. There's a fair amount of research going on and areas of interest. So why is objective testing important? And this is something that I, as a peripheral nerve specialist, deal a lot with, which is, do you have small fiber neuropathy or not when your EMG is normal? And while EMG is easy, or large fiber neuropathy is easy to capture on EMG, small fiber can be trickier. And so it often comes up, you know, do I have fibromyalgia? Do I have small fiber neuropathy? What do I have? And small fiber neuropathy, by definition, is when patients have early small fiber involvement that is preferentially present or preferentially defines the disease course. And so patients who have large fiber involvement might have balance problems, weakness. Small fiber patients usually do not have those symptoms. They don't typically have balance or weakness issues. Their vibration and position sense testing is normal. It's really just predominantly a dysfunction of pain as well as temperature perception, so cold and heat perception. But why is it important? Not only can it precede large fiber involvement, so it can be a warning sign of large fiber injury later down the road, but it's also reversible. Okay, and I'll talk about that later today. Again, it can be reversible. Not all types are reversible, but it is much more reversible than large fiber. And it also, when we test for it and show that there's objective evidence of small fiber involvement, we can, beyond a shadow of a doubt, know that there is small fiber injury and separate that from patients that might have what we call central pain disorders, you know, problems with pain perception. So fibromyalgia, what's called central pain syndrome, or somatization, which are both equally debilitating but are different disorders. At its core, good history and exams should uncover small fiber neuropathy. This is a little bit technical, but I'd like the audience to be aware that there are different fiber types when we as neurologists approach neuropathy. Starting from the largest to the smallest, there are A beta fibers, B delta fibers, and C somatic fibers. As you'll notice, A beta are large and myelinated, meaning they are covered in an insulation, the myelin. They conduct rather fast. These fibers control vibration and position sense. The A delta fibers are small and myelinated. They also have that insulation, and they perceive cold temperature, and they conduct about 20 meters per second. At the very bottom, we have what are called C somatic fibers, and these are small, unmyelinated, meaning they do not have that insulation. These conduct heat or temperature sensation, specifically thermal heat perception, and these conduct the slowest. So when we are testing for small fiber neuropathy, we are typically looking at these small unmyelinated fibers, the C somatic fibers, on skin biopsy, which I'll talk about later. A beta is picked up usually on EMG testing, and then the C somatic are really the fibers of interest when we're looking at a small fiber on skin biopsy. It is important to realize that even though small fiber neuropathy involves small fibers, they are not insignificant by any means. As you'll note from this point here, most of our fibers are small diameter. So 2/3 of any human being's fibers are, or 2/3 of myelinated fibers are small diameter, meaning for every 3 myelinated fibers, 2 out of those 3 are A delta fibers. Also, the unmyelinated to myelinated ratio is about 4:1. So out of every 5 fibers, 4 are going to be C somatic. Okay, so our nervous system is predominantly small fiber, peripheral nervous system. I wanted to make a point, because this is a point of confusion sometimes, that you do also have C autonomic fibers, but these are part of your autonomic nervous system. And these, without getting into too much technical detail, control sweat function. These are tested on what's called a QSART or Q-sweat machine, which is part of the autonomic testing. And that's kind of the only point I wanted to make from this slide. So let's focus this first section on somatic sensory testing. Again, by somatic, I'm referring to fibers that control sensation as opposed to autonomic fibers. So these are ways that we can look at small fiber integrity and function. Let's start with corneal confocal microscopy. So this is a modality that is still not by any means a gold standard. It is mainly used in the research setting, but I wanted to bring it up because it is an interesting modality in which samples of the cornea are looked at under this specialized confocal microscope, essentially, to evaluate for the density of these skin fiber, these small fiber endings. And it has been shown these fibers are specifically in the subbasal nerve plexus of the cornea. Okay, so this is an in vivo measure, meaning it's done in the tissue itself. It does not involve an extraction or a biopsy in which the sample is taken out. It has fair accuracy, but most experts in the field who specialize in sort of small fiber neuropathy testing and evaluation would certainly say it's not as good as intraepidermal nerve fiber density or skin biopsy, but it has some potential benefit. And it seems to track improvement in diabetic patients in certain settings. But this is mainly a research application. Skin biopsy, which we'll dedicate the majority of our talk, of our testing portion today on, is really the gold standard. And it involves this 3 millimeter punch biopsy that's done at different sites where you actually get a visualized image under the microscope of the density of small fiber nerve endings. And so, for example, panel B here on the right, you can see a greater density of black, essentially these fiber buds or endings terminating in the epidermis. Here on the left in A, there's not as much. So this would show reduced density. So for example, taking a diabetic patient, you can imagine that given the stocking glove distribution of nerve damage in diabetes, you'll have more dropout in a length-dependent patient distally as compared to higher up in the thigh. So as we said, this assesses somatic C fibers. You recall the ones that perceive thermal sensation or heat. And these are different from the autonomic small fibers, which terminate in your sweat glands or blood vessels. You can do different sites, so you can do the distal leg, you can do the distal thigh, or you can do the proximal thigh. And these are just 3 commonly used standardized locations that have some normative data. The best normative data we have is for the distal leg, but most of us, or most centers, will do at least 2 or 3 sites to sort of look for a pattern. Okay, these fibers, once they're collected and processed, are stained with this pan-axonal marker protein to look at the fiber density. Here's an illustration of what is seen under the microscope in terms of a normal healthy amount of terminal fibers in the epidermis on the left. Then on the right, you have a normal thigh and a normal calf, and then a diabetic thigh and a diabetic calf. So a couple of observations. Density does seem to drop out most patients in the thighs compared to the calf, even in healthy normal subjects. And that is factored in when we're looking at normal densities. No surprise, diabetics have a reduction in these fiber endings. compared to normal healthy controls. So this is an important point to be aware of, that skin biopsy is currently the best and gold standard for diagnosing small fiber neuropathy objectively. Moving on to other modalities. These are testing modalities that are probably going to show up mainly in research settings. They are not as used as widely in the clinical setting, but are still worth discussing. Quantitative sensory testing, or QST, is used in clinical settings in certain institutions like the Mayo Clinic, for example, but it's not nearly as widely used as skin biopsy. And essentially what happens is you are applying a certain stimulus. It could be heat, it could be cold, it could be vibration, and noting when the patient first picks up this sensation. So it's a threshold testing. And it's been shown to be helpful when looking at small fiber neuropathy in diabetics at capturing early diabetic small fiber injury, and at distinguishing painful from non-painful small fiber neuropathy, and distinguishing healthy patients from those with small fiber. The challenge is there's lack of consensus on stimulus application, location, and sensations tested in terms of making it standard universally. But I will say that this is a very valuable adjunct, and certain countries, for example, in Germany, where they have a very good standardized consortium for testing like this, it could be used more widely. But in the US, for example, most academic centers, I would say, or most centers in general, don't use it. Some do. It's still a valuable adjunct to skin biopsy evaluation. There are other tests that are certainly not nearly as widely used. I just wanted to bring these up in case you've come across them. They might have a little bit more of a commercial application, but they've still been studied and still have some value. So I would not discount these, but they're just not as widely used. So the neurometer, same idea, but it uses sort of a current instead of a temperature or heat sensation, and it selectively stimulates different fiber types and uses sort of similar principles to kind of, for perception testing. NeuroQuick is similar in the sense that, again, you're using threshold testing, but it is specific to cold perception threshold. So the patient notices when they first perceive that cold airflow. So as you can imagine, if it's cold, it's going to stimulate those A delta fibers. There is also what's called a neuropad or plaster test. Again, not as widely used, but still studied and has some value. This looks at the autonomic C fibers. So if you recall, the autonomic C fibers are looking at your sweat and the autonomic fibers that control your sweat and blood vessel control. So this looks at the fibers that control your sweat function. And if you have normal sweat function, it should change color. If it doesn't change color, it tells you there's damage to those small autonomic C fibers that control sweat. And this can be used as a surrogate of small fiber neuropathy. There's something called a pseudoscan. So the pseudoscan is also something that has looked at a sort of point of care testing. It's an electrochemical conductance test, essentially, where the subject places their palms and soles on a preset sort of insertion sites, and it essentially applies this low voltage constant electrical current and essentially measures conductance. And this is another measure using the sweat function. But again, I would say that these tests are valuable. They have clinical and research application, but not as well validated or standardized as skin biopsy. Skin biopsy is the gold standard of objective small fiber testing. As we said and alluded to, autonomic testing often overlaps with small fiber testing and can be used as a corollary to evaluate for small fiber sensory loss. And specifically here, we're talking about the autonomic reflex screen, and specifically the QSART, or quantitative pseudomotor axon reflex test. So I just wanted to point out that autonomic reflex testing is used in many labs across the country. We do it here at Michigan Medicine, and most institutions, I think, or most states, I should say, will have at least one lab. And this looks at different fiber types, so small fiber, sweat fibers, cardiac vagal fibers, adrenergic fibers, but we are specifically interested in QSART testing. Thermoregulatory sweat testing, which is used in a certain number of institutions across the country, not as many, is another valuable modality, which looks at your sweat fibers and can thus also look at small fiber injury. So the sweat test, or QSART, essentially is based off of this concept of what's called a pseudomotor axon reflex. Without getting too technical, testing sites will apply acetylcholine gel over a patch of skin in a multi-compartment capsule. A current is run through, and using this sort of naturally built-in reflex that our bodies have, when that sweat gland picks up acetylcholine, an adjacent sweat gland starts to sweat. So you're actually measuring the sweat volume produced from an adjacent sweat gland. And this can tell you how those small C autonomic fibers are doing, but by extension, those small fibers that are also somatic typically get also involved. You can use this to look at a pattern. So for example, in this subject, the foot is not sweating that much, the distal leg a little bit more, the proximal leg a little bit more, the forearm normal. So this is what's called a length-dependent pattern, which would also mimic length-dependent pattern on your exam or a length-dependent pattern on your skin biopsy. Thermoregulatory sweat test, as I said, is sort of used at a few centers, not as many, and essentially applies this indicator powder over a subject and places them inside this heated enclave. And the percentage or total body surface area of spots that are not affected will show you sort of the pattern of small fiber involvement. So in this subject, for example, your head and upper body is not sweating. You can imagine if you're a diabetic with length-dependent sweat dysfunction, the feet won't sweat as well. So another useful test, but not as widely available. And this can show you length-dependent patterns of small fiber like diabetes, erythromelalgia, Fabry's disease, or length-independent patterns like Sjogren's, paraneoplastic, or leprosy, amongst others. I just wanted to include a couple of slides on research that's been done looking at autonomic impairment and painful neuropathy. So this is, again, skin biopsy is the gold standard, but autonomic testing has been well validated in evaluating for small fiber neuropathy. So this is from the Ohio State group I previously practiced and essentially looked at 92 subjects and found those with painful neuropathy, half with abnormal, half with normal nerve conduction studies, and showed that they had a fair amount of autonomic impairment on autonomic testing. So about 72% had QSART abnormalities, 63% cardiac vagal, 42% orthostatic hypotension, and there was a fair correlation between QSART and skin biopsy testing, with those who had abnormal nerve studies having more severe autonomic changes. So sort of, pearl number two, if I had to say one, was autonomic impairment often goes hand in hand with small fiber neuropathy. So that is a valuable sort of finding that might assist patient evaluation and might be worth evaluating for other reasons that we'll discuss. This was from the Mayo Clinic group and looked at about 125 patients with distal small fiber neuropathy per nerve studies or history, and basically looked at the prevalence of QSART or thermoregulatory sweat testing abnormality, which was seen in about 93%. QSART showed a length-dependent pattern in about 62%. And as you can see, the vast majority of these patients, interestingly, 125, were idiopathic. So as I'm sure many of you might know or might have heard, it is a great frustration for patients to be told at the end of multiple visits and multiple evaluations that we don't know what's causing your neuropathy. But I don't want you to let that frustrate you, because you are not alone, despite sometimes the best testing and the best evaluations. very big chunk of patients can still have idiopathic neuropathy. I wouldn't say as high as 73%, probably closer to maybe a third to 40% still don't have a clear cause, and that's okay. Speaking of, let's talk about the causes of small fiber neuropathy that we know. So this is a nice review from the early 2000s. It looked at small fiber neuropathy, looked at various causes. I highlighted some that are probably more important. I shouldn't say more important, but more that come up more often, I think, in discussion. Certainly Sjogren's is really important. We'll talk about that. Amyloidosis is a hot topic these days with now 3 FDA-approved therapies. Fabry's and hereditary sensory neuropathies are important because Fabry's has a treatment available. Hereditary sensory autonomic neuropathies, are valuable. They are the subject of, drug trials and might be valuable. But I think I bring them up here because they're often not as, I should say, screened for as aggressively, but might be worth keeping in mind in the differential. But they are quite rare disorders. So common things being common, and again, this is something that I can't stress enough. Common things are common. Make sure you get a good workup for common things before you pursue an extravagant workup for uncommon things. So again, not rocket science. Diabetes, and prediabetes are huge. Alcohol and thiamine deficiency are really important to think about, and I think are underdiagnosed. I tell all my patients, I'm not judging you. It's not a guilt trip. It's just a matter of possibility. So you don't have to be dependent or abusive to possibly have alcohol-related neuropathy. How much is too much? I don't think anyone really knows, but I tell patients if you're having a couple of glasses each night or most nights of the week for 20, 30 years, it might be worth considering as a possibility. B12 deficiency, MGUS or monoclonal gammopathy of undetermined significance, and then chemotherapy. So diabetic neuropathy and prediabetic neuropathy are really important. I'm not going to go into too much about the diagnostic criteria other than to say A1C alone is not enough. You should probably have at least a fasting blood sugar at some point in time or a 2-hour glucose tolerance test at some point in time. And using these cutoffs listed here, you're labeled as either a diabetic or a pre-diabetic. So impaired fasting glucose of over 100 renders you a pre-diabetic. An impaired glucose tolerance test of over 140, which is the 2-hour glucose tolerance test, also renders you a pre-diabetic. Once you hit fasting over 126 or 2-hour over 200, that is a frank diabetic. So this notion that my A1C is under 6.5, it excludes diabetes, is a false notion. It is not 100% sensitive. So I always tell patients you should probably get a fasting or 2-hour test at some point in time. What do we do for diabetic neuropathy? Well, there's a lot of emerging data, as I'll talk about later, on the role of moderate intensity aerobic exercise or high intensity interval training. The key numbers I tell my patients are 30 minutes a day or 60 minutes 3 times a week. Could be rowing, could be biking, could be swimming, could be walking. From work that's been done here at Michigan Medicine by Doctors Eva Feldman and Brian Callahan, amongst others, in the field nationally. Glycemic control is certainly important for type 1 diabetics, but not as impactful for type 2 diabetics. So for type 2 diabetics, really the emphasis is on controlling those metabolic syndrome risk factors, exercise, diet, weight control, amongst others. I often recommend alpha lipoic acid 600 milligrams once a day, even though the trials did not meet FDA approval, but there were some trends towards possible benefit. One pearl is that patients who are on metformin for type 2 diabetes have been shown in some studies metformin to be associated with B12 deficiency. So just be aware to get your B12 checked, especially if you're on metformin. Pain management, of course. Can diabetic overcorrection cause neuropathy? Absolutely. So if you drop your A1C level more than 2 percentage points over 3 months, you can cause treatment-induced neuropathy of diabetes, or what's called TIND. And this can happen about 2 to 6 weeks after the glycemic overcorrection, and it can be length-dependent or independent. Just to step back for a moment, length-dependent simply means that your pattern of nerve injury is in a stocking glove distribution. So it starts in the tips of your toes, works its way up, fingertips works its way up. Length independent is when it is patchy and does not respect that principle. So you might have damage in your hands, your left hand, then your right hand, then your left foot, your face even. That is what is meant by length independent. It does not follow that stocking distribution at onset. What about chemotherapy-induced neuropathy? This is a big problem, very painful, often leads to change in chemo regimens if the pain is too severe. It can occur immediately, subacutely, or chronically after exposure. Certain drugs have stronger associations. Certain drugs are more dose-dependent. The good news is most are sensory related. They don't lead to motor deficits, meaning typically you don't develop weakness from the chemo, but it does happen with some drugs. And depending on the severity of the neuropathy, the oncologist may choose to switch the chemo, but I always tell my patients, don't let the side effect tail wag the dog. So treating the cancer still takes precedence over the side effects, but if the side effects become so severe, then it may be worth considering an alternate drug. B12 deficiency is very important. Most patients don't realize it can give you peripheral nerve, but also spinal cord damage. Okay, so this is what's called myeloneuropathy when you affect the spinal cord and the peripheral nerve. If it affects just the peripheral nerve, it's called polyneuropathy. How do you know if a patient has spinal cord? Well, you test their reflexes at their knees and their breast, possibly, amongst other findings. They might have bladder dysfunction. They might have spasticity. B12 can also give you systemic signs of deficiency, so confusion or memory loss, depression, vision loss, and might have dryness of your tongue or other deficits throughout. So some patients, you might want to have brain or cervical spine imaging pursued as well. This is a really important point. Again, I think another really important pearl or take home is that, yes, in the US, a 200 cutoff is used as deficiency. But I've seen patients with values at 250, 290, who are bulimic, who've had gastric bypass surgery, who have clear signs of B12 deficiency, be told that their B12 is normal. So just have a bit of a flexible mindset when approaching this topic. In Europe, they use a cutoff of 400, which I prefer. I'm not saying I'm right and other doctors are wrong, but I just like to be a little bit more flexible in diagnosing B12 because I think it's underdiagnosed and can lead to major damage, as we said. Certain populations are higher risk: alcoholics, vegans, those who've had bariatric surgery, those who have malabsorption from pernicious anemia or inflammatory bowel disease, metformin users, and anorexic or bulimics. Treatment is a bit of a personal decision. I personally put all my patients on 2,000 micrograms daily of B12 oral. And then I also supplement with intramuscular for at least a year. Again, this is not a gold standard. This is not, the one and only treatment. That's just my personal practice choice based off of my training. If they have deficiency, I'm worried about B12, I'll do IM and oral for a year together and then continue them on oral afterwards. IM regimen that I use is daily for a week, weekly for a month, and then monthly for a year, about 1,000 micrograms. But everyone is different. So just be aware that this is something, patients, different doctors are going to treat differently. Alcohol and thiamine is really important. There's no good way to know how much is too much. The CAGE questionnaire, which we are taught to use to look for alcohol abuse or dependence, is really not a very sensitive measure. So you might want to look for subtle clues. So if there's magnesium or phosphorus deficiency, borderline B12, chronic daily use, you might want to consider treatment. The B1 or thiamine test is helpful, but not always accurate. So I just often go ahead and counsel patients to try to cut down on their consumption and to take 100 milligrams daily of B1. And thiamine deficiency, as with B12, can affect other organs. It can give you hoarseness of voice. It can, be present in patients in underdeveloped parts of the world and can lead to what's called wet beriberi, where they have congestive heart failure. In the US, I've only seen it severe enough to cause hospitalization when patients have had bariatric surgery, significant weight loss, significant malabsorption, and then they go in with significant B1 related complications. But in most outpatients, it's really quite mild, but worth thinking about. Less common but important causes that we'll talk about are Sjogren's, amyloidosis, and then just be aware that hereditary sensory autonomic neuropathies are also important in the small fiber field, amongst other conditions. We're running a bit short on time, and I wanted to go through the slides, so bear with me. It's going to be a little bit of a whirlwind here, but this is a study that was done, I believe, in the early 2000s that looked at small fiber presentation, and this was kind of helpful. And most patients out of this cohort of 32 had the chronic progressive month-dependent pattern, while a small minority had an acute generalized hypersensitivity. Okay. The point that was made here is that skin biopsy testing was able to capture that some patients had greater reduction distally as compared to proximally. And those were the ones that were length dependent, the typical majority of patients, but a subset had equal reduction, both at their thigh and their distal leg. And these are what are called length independent. And length independent, like I said, means it's affecting sites in a patchy fashion, okay? And it tends to be more autoimmune related. This was a separate study that identified 68 patients with pure small fiber neuropathy. Up to 41% of patients did not have a clear cause. At 2-year follow-up, about a quarter of those, it was determined what the cause was. So you're still left with about 30 to 40% of patients on average not having a clear cause of their neuropathy, small fiber wise. This is a small slide, but it's just showing that, out of 125 patients, for example, 67 had small fiber neuropathy. Out of those, you identified the majority had diabetes or prediabetes or Sjogren's, monoclonal gammopathy, celiac. About 28 did not have a cause. So that's a big chunk of those patients. And at 2-year follow-up, still 26 out of 28 did not have a clear cause. So that is what we call cryptogenic or idiopathic neuropathy. Sjogren's is really common. I always ask about it. I always look for it, especially in patients that have dry eyes or dry mouth or sicca symptoms, and should always be considered. Any patient who has a length independent pattern should always be screened for Sjogren's. And I always tell my patients, even if you don't have dry eyes and dry mouth. This is another study looking at a non-length dependent pattern of neuropathy, and it just basically showed that the most common diagnosis was Sjogren's. How do you go about diagnosing Sjogren's? Well, the lab testing is not the most sensitive, so we often will do what's called a minor lip salivary gland biopsy, which ENT or rheumatology can do. Hereditary amyloidosis is really important. It involves the production of a mutated protein, the TTR protein. This is different from AL or acquired light chain amyloidosis. It is now commercially it's available commercially through free genetic testing. And what's really nice is there's 2 and now 3 FDA-approved therapies that are gene modifying. You should ask about if you have this genetically confirmed amyloid neuropathy, because it will actually not only stabilize but reverse the disease course. Hereditary sensory autonomic neuropathy is another topic of interest, and this is just a publication about family members that might have it. So sorry for the smallness of the slide, but there's 5 major subtypes, and you want to ask about foot ulcers or bone deformities or hearing loss or symptoms like lack of tearing or lack of sweating in infancy, and that should really raise concern. I think we don't do a very good job, at least I don't, always screening for it, but something to think about if you have a congenital onset neuropathy. I know we're at the 40-minute mark, so Lindsay or Tanya, if we want to do a hard stop now, certainly let me know, or I could maybe talk for another 5 to 10 minutes, but please cut me off if we need to do a hard stop.
Yeah, Amro, why don't you keep going? I think we can afford another 5 more minutes. This is great information.
Perfect. So I wanted to touch in the remaining part here on some interesting applications, and then some aspects about pain management, which I know you're all waiting to hear about. So I just wanted to talk about metabolic syndrome, which is this constellation of features that's waist circumference, high triglycerides, low HDL, high blood pressure, elevated fasting blood sugar. You have to have 3 out of those 5 to have metabolic syndrome. So another take-home pearl I want everyone to know is you do not have to have frank diabetes or even pre-diabetes to have neuropathy. You can have neuropathy just from metabolic syndrome. And again, this is something that has been proven really quite substantially through the work of Drs. Brian Callahan, Eva Feldman, others across the country have really shown this association quite strongly. This was a study done here at Michigan Medicine a while ago, which really has been followed with many other studies, showing that patients who had pre-diabetic neuropathy or had metabolic syndrome, which often go hand in hand, could have their intraepidermal nerve fiber densities improved or stabilized through exercise, which is really cool. And these are just showing that the nerve fiber densities at follow-up showed stabilization or improvement. So these small fibers are really quite robust and regenerative and quite hardy in terms of being able to come back. This is a study that was just published from our center. Brian was lead investigator, which showed that dietary weight loss in people with severe obesity stabilizes neuropathy and improves symptoms. So again, this was 131 patients. They had dietary weight loss, about 12 kilos. All aspects of their metabolic syndrome improved except for blood pressure. Nerve fiber densities at 2-year follow-up stabilized, which is actually an improvement because natural history shows decline over time. So for patients who are obese, severely obese, this might be an effective intervention, is to pursue weight loss dietarily. There's actually a study going on right now from our center, which just did recruitment, which I'm involved in as a co-investigator, and Brian is sort of leading this study, looking at high intensity interval training, as well as bariatric weight loss in 4 different arms, okay? So both together, surgery alone, high intensity interval training alone, or neither on small fiber neuropathy function. High intensity interval training is basically a form of exercise in which you have short periods of extremely demanding physical activity alternating with less intense activity. So just keep your eyes peeled for the role of weight loss through diet and surgery on the future of small fiber neuropathy. Topspin was a study I was involved in, both at Ohio State and here at Michigan Medicine, which looked at Topiramate, which is a weight loss drug. Unfortunately, did not meet its primary endpoint. We sometimes still use Topiramate for pain control on the basis of a 2005 study, and the authors did find that it might improve quality of life, but I think the data is still not published, but the primary endpoint was not met, unfortunately. Erythromelalgia is an interesting area where you have red hot, painful extremities provoked with heat, relieved with removal of heat. And this is just a point I wanted to make, that they actually are a subset of small fiber neuropathy that have both vasculopathy or vascular dysfunction and neuropathy or nerve dysfunction. Again, this was done at the Mayo, just showing what I just said. Fibromyalgia is an area of great debate. I was just involved in a study, a small single center study looking at this. Can we distinguish patients who have fibromyalgia alone from those that have fibromyalgia and small fiber neuropathy on the basis of symptoms alone? And the answer is no. So symptoms alone do not distinguish patients that have fibro and small fiber from those that have fibro alone. If you do a certain nerve test, I believe it's the medial plantar, it did seem to be affected more in those that had superimposed small fiber neuropathy, and those did seem to have more glucose dysregulation, but in general, symptoms alone did not distinguish. So in the last, just give me 2 more minutes and I'll wrap up here, but pain management is a huge topic. And the point here is you want to go class by class: gabapentinoids, tricyclics, SNRIs, and then sodium channel blockers. These have been codified in the American Academy of Neurology diabetic neuropathy pain guidelines that were recently published. So the general idea is start low and go slow. Give each drug at least 8 weeks before you call it a failure. Set expectations. We might not be able to take the pain away completely, but we try to reduce it, ideally by about 50%. And then find out what the side effect is. Can you actually reduce the drug to remove side effect, or do you have to toss it out completely? Make sure there's no drug-drug interactions, because that's another big problem. So I usually personally start with gabapentinoids, so pregabalin or gabapentin. You want to, again, start low and go slow. Can increase in weekly increments or every 3 days to your target dose, which can be 600, 3 times a day, some up to 900. I rarely go up to 1200 3 times a day. Pregabalin is a good option, but it tends to be a little bit more costly. In the second class, the tricyclic antidepressants, you have nortriptyline or amitriptyline. I'm biased towards nortriptyline just because the side effect profile is less than amitriptyline. Make sure there's no drug-drug interaction that can cause QTc prolongation. It's a really good option for those with insomnia and migraines. Third class is SNRIs. So these are things like duloxetine or venlafaxine. Again, duloxetine usually 30 a day for a week, then 60 daily thereafter, and you can go up to 60 twice a day. And venlafaxine is favored in the extended release form. Again, you want to give drugs at least 8 weeks, 6 to 8 weeks at maximal dose before you call it a failure. And fourth, I want to really bring your attention, another pearl or take-home point is mixilotine is a really good underused drug. Most patients that have come to me that have seen, 3, 4, 5 different neurologists sometimes, I'll often be surprised that no one ever thought of mixilotine, and it works very well. It's a sodium channel blocker, initially developed for arrhythmias or heart rhythm problems, but we use it works really well for pain. Just want to have a baseline EKG, and then you start again low and go slow. So 150 at night for a week, 150 twice a day, and then 150 3 times a day. Other drugs that I'll mention, I can't go into too much detail for time, but topiramate might be helpful, for pain. I've had good success with it, but you want to monitor for kidney stones history. And then oxcarbazepine, as well as carbamazepine are 2 other good ones, but you have to monitor for low sodium, and lamotrigine, you want to monitor for Stevens-Johnson syndrome, which is quite rare. Again, in summary, make sure there's a good history, good exam, corroborate that with good objective testing. If possible, skin biopsy is not absolutely necessary, but if you want to get a test, it should probably be skin biopsy. Go through the common things first, and then look at the uncommon things. If it's length independent, definitely think of Sjogren's. Then recognize that you can sometimes also have large fiber involvement, but it's still small fiber predominant. Okay, with that, I'd like to thank you for your attention, and I'd open it up to questions. And I apologize, Lindsay and Tanya, for going over.
No apology needed. This is fantastic. We did receive a million different questions, so apologies to all of those that we're not going to be able to get at this current session, but we will try our best to follow up. So you listed a gamut of drugs and also other kind of lifestyle changes. that people can undertake to kind of help improve their symptoms. And one of the questions that came in that we hear all too much is when drugs and physical therapy and diet and other types of treatments like spinal cord stimulators, acupuncture, when all of that doesn't help relieve the pain, what should a patient do? What's the next step other than give up? Because at the end of the day, there's always hope that there can be something that can help relieve it.
Mm-hmm. Yeah, that's a common problem and a really good question. Hopefully it'll help other patients on the call too. So I see a lot of patients who are told they have small fiber neuropathy or peripheral neuropathy who actually have pinched nerve roots in their low back. So lumbar radiculopathy is a really common problem that people, I don't know why, because somehow someone put the label neuropathy, no one thinks to look at the low back. And the low back is a huge source of foot pain that you have to think about, because it doesn't always cause low back pain and sciatica. It can just be foot pain or distal leg pain. But what you want to think about is it asymmetric? Is there a history of low back discomfort? Is there a history? So definitely think about an MRI of the low back. And I would just say, you know, to get a new set of opinions. So if things are just not working, seeing a specialist or a peripheral nerve specialist or a pain specialist always helps, because not everyone does spinal cord stimulation with the same quality. Not everyone does physical therapy with the same quality. Not everyone manages with the drugs the same. So I've had a lot of patients where they'll try a drug for 2 weeks or a month and they say it doesn't help, and they weren't tried for 2 months, for example. So there's a lot of nuances there.
Yeah, and I think, as you had mentioned also towards the end of your presentation as well, I think 6 to 8 weeks is typically the standard bar of trying something new before you give up hope that it hasn't helped,
Right.
because it takes that long for your body to respond.
Absolutely.
So do you know offhand, and this might be an impossible question, so apologies for putting you on the spot, but do you know what percentage of the population who has small fiber peripheral neuropathy has a mild case versus a severe case? I mean, are we 50-50, or what are your thoughts on that?
Yeah, I think the way to sort of stratify severity for small fiber will really be by pain. And so if I were to look at painless versus painful, I think that, again, this is just a guesstimate from my experience managing over the years. I would say that probably when you're dealing with small fiber, there's going to be a higher percentage of pain compared to just all comers with large fiber as well. So I would say it's probably skewed towards 75% being painful, and then 25% might be painless. Most have some pain. Out of the 75% that have pain, I would say probably 2/3 are at least moderate to severe, and then a third might have mild pain. But yeah, I mean, it's a debilitating condition, because I think like most patients are going to have at least moderately severe pain.
Yeah. And has there been any new or recent advancements or even future hope for stem cell treatments in the field of neuropathy or small fiber neuropathy specifically?
Yeah, so I think the short answer is not currently, but I know that there's a lot of active research going on with gene therapy. Hopefully we reach a point when we can sort of optimize the pharmacogenomics of it, so you can get a sense of who has a certain mutation or pain profile and give them a targeted drug. But stem cells, I don't know if it's going to be accepted by all patients, because it's a little bit of overkill for some. I mean, I wouldn't say it's overkill for pain. Pain is certainly debilitating, but it might not be. It might be a little bit too invasive for some patients. So I think it's hopefully going to be a pharmacogenomic approach where you can tell what the profile is and go straight to that drug rather than trying 4 or 5 before.
And what are your thoughts about IVIG, specifically for idiopathic patients? Obviously, you might have a different answer for all of the different types of causes of neuropathies, but we have a lot of idiopathic patients. Obviously, their cause is unknown. They try a lot of different treatments. Is IVIG something that you think could be an option?
So I think it kind of goes back to that issue of the appropriateness of the treatment for the complaint. So I have used IVIG in select patients who have not only small fiber neuropathy, but debilitating autonomic neuropathy. So severe gastroparesis or slowing of their gut or severe orthostatic hypotension. But I have to say, for just small fiber neuropathy alone, I don't use IVIG because IVIG carries risks of clotting. It's very costly. Patients pay a lot out of pocket. Yeah. And from a just efficiency economy standpoint, it's more about finding the right lock and key pain management fit. So I try to really optimize the nerve pain medicines rather than do IVIG.
Great. You had mentioned at the start of this, and I'm not going to quote you, so if I say something wrong, please correct me, about, reversing some forms of neuropathy or perhaps even curing neuropathy. Could you comment? I know that's a very big question, and depending on the length of time we have, we might have time for another one, but could you comment on that?
Yeah, so these small, the nice thing about small fiber nerves is they're very regenerative. So that kind of makes them ideal for research studies. So exercise, for example, in small sort of non-randomized control studies has been shown to improve nerve fiber density at the end sometimes as soon as 10 weeks. I think that we'll see what comes of the current study that Brian's running, Brian Callahan, on surgery and high intensity interval training on does it actually reverse it or is it just stabilizing it? We've seen that dietary weight loss stabilizes the drop off. But I will also say that in hereditary amyloid, those two new FDA approved therapies, some of the outcome measures, now I don't believe they were skin biopsy based, but it did show not only stabilization, but improvement in disease burden. So I think it's very plausible that you can reach a point when you can go, I don't know if we can go back to baseline, but go pretty close to baseline if properly treated, because these nerves have a really good ability to regenerate.
And last question, which is kind of the big picture research future question. Do you have any thoughts on what might be in the pipeline in the future, whether it's treatments, more answers, more research findings? Is there a specific niche where you're seeing a little bit more quicker results than others, maybe?
So I think that diabetic, pre-diabetic, and metabolic syndrome neuropathy, I think the paradigm is going to definitely change. Where if I were to guess, I think that the sort of whether it's high intensity interval training or certain exercise will be prescribed like a drug for stabilizing or reversing neuropathy. So again, maybe in our minds we sometimes dismiss exercise. It's not, a cool drug or whatever, but it seems to be, at least from the data we have, quite effective. So I think that should become more standardized for diabetic, pre-diabetic, metabolic syndrome patients. For amyloid, I think there's a lot already there. I think for erythromelalgia, which I touched on briefly, again, whenever you have a specific diagnosis, that will really help sort of the research element. But again, pain is front and center, the biggest problem for patients with small fiber. And I think that there's a lot of work being done on phenotyping or genotyping pain profiles and knowing what drug works for them. And right now, it's basically just trial and error. We have no idea who's going to respond to gabapentin or duloxetine, or we just try. And that can really be a problem for patients if you're waiting years before you get good pain relief.
Right.
I think spinal cord stimulation is also exciting. There was a trial that was done that did show some promise, but it hasn't really been standardized or universally adopted for refractory pain. But that's something that I didn't talk about, but I've used that through the pain clinics for pain management. But I think, I think pain will really evolve in its management for small fiber.
No, and that's promising. And I think, you know, at the end of the day, that's kind of what the foundation is here for as well. We're a resource where we have connections to you and a lot of other of our scientific advisors and researchers and medical experts in the field, where if you guys have questions about a specific treatment option, we can at least tell you if it's a possibility. But at the end of the day, we always encourage everyone to seek specific personalized medical consultation within your own spectrum, just because nothing is working for everybody right now. There is no one cure or one answer, but I think that there are a lot of different options out there, and hopefully one or at least a mix of various ones will at least improve the quality of life. And that's the goal at the moment, but tomorrow is another day, so we're hopeful as well. Well, with that, thank you. We unfortunately ran out of time. This was an amazing topic and amazing presentation. As I said, I'm very sorry that we weren't able to get to all of the questions that were raised throughout and even before the session even started, but we will try our best to do as much follow-up as we can. We will be, again, highlighting this webinar on our website, so a recording will be uploaded by tomorrow. So if anyone wants to rewatch or get a transcript of this, or similarly gain access to the PowerPoint slides, excuse me, all of that will be provided. And again, we appreciate everyone just joining these types of programs. They're really fantastic, and it really allows us an opportunity to get our patients in front of experts like yourself. So thank you for participating with us as well.
Thank you, Lindsay. And if you do want to forward me any of the questions too, like I can be happy to answer those and get back to you as well. So. Well,
thank you. We might take you up on that one, so be careful what you ask. But no, that would be really appreciated. Thank you so much.
Awesome. Thank you.
Okay, well, again, thank you everyone for joining. Hope you have a good rest of your day. And if you need anything, just let us know. Bye-bye.
Bye-bye.